Hello, a very good evening to all of you who are joining us for this DigiFest session, supporting mental health and well-being, and obviously a very, very important topic. And I'm delighted to introduce our two speakers this evening, Dr. Will McMurchie, who's a clinical psychologist at NHS Tayside, and Chris Wright, who's the National Advisor for Digital Mental Health at Scottish Government. Chris and will do a short presentation, but be really good to get your thoughts, your comments, your questions, and we can have hopefully a bit of a discussion after the presentation. So I'll hand you over now to Will and Chris. Thank you.
So hi there, good evening to everyone. As Margaret was saying, my name is McMurchie. I'm a clinical psychologist in Dundee, which is in the northeast of Scotland. My clinical work is primarily in a community mental health team, working with people with severe and enduring mental health difficulties. But I'm also the clinical lead for our computerised CBT service, which is the primary reason really for presenting this evening. So if you bear with me 2 seconds, I'm just going to bring up my presentation. And then hopefully that's coming up for everyone. So just in terms of an overview of what I was hoping to cover today, I was planning on giving a bit of basic background information, really exploring the rationale for why digital interventions are relevant within mental health services, giving some information about the two packages that we are primarily using in our service at the minute, which is Beating the Blues and Silver Cloud, giving a brief summary of just how the service operates in practice, and then linking into Chris's presentation, just giving a very brief bit of information about the kind of national perspective of how digital mental health services are operating. So in terms of some background information, common mental health difficulties such as anxiety and depression are hugely prevalent issues in Scotland and indeed throughout the rest of the UK and the world, affecting around about 1 in 5 adults at some point during their lifespan. Certain long-term health conditions such as diabetes and chronic pain conditions also increase the prevalence rates and the likelihood that a person could develop something such as anxiety and depression. And I guess one of the knock-on effects of that is that a huge amount of GP consultations are taken up in terms of dealing with common mental health difficulties. One of the knock-on effects of that is that there's significant demands upon mental health services. And with that, there's kind of long waiting times to be able to access things such as psychological treatments. And I guess one of the things that's come really to the forefront is that the COVID pandemic is only really likely to increase these issues, where issues such as social isolation, bereavement, people losing their jobs, makes sense that it's going to lead to an increase in certain mental health issues. And then if you link that with things like GP time potentially being taken up in terms of dealing with the rollout of the vaccines, there's likely to be huge demands on services with an increased demand and potentially less resources to meet that demand. So I guess what we need is solutions to that problem. And the fact that we're doing this conference in this manner kind of really suggests, the way in which we're looking to solutions at the minute is very much in terms of technology. And this picture here I kind of put up is just a reminder of how I learned about things like the internet. This was the kind of model of computer that was kind of available during my school years, and I can still remember the very first time we logged onto the internet on a computer not too dissimilar to that. Fortunately, however, technology's advanced since then, and hopefully some of you might be sitting in front of a setup such as this, Unfortunately, mine's is not quite as grand as what's up on the screen here. But I guess the main, I suppose, implication of this is that advancements in technology have offered a high capacity treatment option, whereby certain psychological treatments can be replicated within computerized treatment programs and then delivered through the use of technology. And a particular type of psychological treatment called cognitive behavioral therapy lends itself really well to this. CBT is a highly structured treatment that involves the patient being taught by the therapist a range of different skills and techniques to help them manage their mental health difficulty. So those same techniques can be replicated within computer programs that we call computerized CBT. Within that, there's also administrative support that's provided that's really about enhancing engagement and addressing technical issues. So developing psychological treatment in this manner can mean that we can offer it to large numbers of patients without the need to wait for a therapist. And the evidence really suggests that this is both an acceptable and an effective treatment for common mental health difficulties. And although I've kind of spoken about it there in terms of maybe some recent advancements in technology, this form of treatment's been available within our department for over 10 years now. So it's not something new that we've been using, but it's certainly something that's really developed very rapidly over the past 2 years in particular. So historically, the main package that we've used in our department is called Beating the Blues. This package consists of 8 sessions that are all based on CBT. The program itself is highly interactive, so it involves watching things like video clips where patients will describe their own experiences of experiencing depression and anxiety and how they use different techniques within the program to help them manage those issues. It involves following a series of case examples, and the patient kind of completes different exercises to be able to learn different CBT techniques to help them cope with and manage their difficulties. It's an incredibly simple program to use in terms of sort of knowledge around computers. So we did, for example, a research study looking at implementing this with older people and found that it was something that with very minimal support they were able to access without any issues. It's now available on things like smartphones, tablets, computers and laptops. So something that can be used kind of in a highly flexible manner in a place and a time that's convenient for the patient. In terms of who it's for, it's primarily directed for patients with mild to moderate symptoms of depression or anxiety. And it's really seen as a first-line psychological treatment who are likely to be initially seen and managed within a primary care setting. So the vast majority of our referrals come directly from GPs. And it really offers an alternative treatment to things like antidepressants. The exclusion criteria that we kind of have are pretty common sense things, really. Things such as if the patient's actively suicidal or they have a more severe and enduring mental health difficulty, or if there's significant cognitive impairments, problems with substance misuse. And at present, the program's only available in English. Part of the reason why we've used Beating the Blues in the department is that there was a really strong evidence base behind it. So there's been a number of randomized controlled trials and then subsequent effectiveness studies, including research that we've conducted with a local population within our department, really demonstrating significant improvements within a range of different clinical settings. And those improvements really are not just statistical improvements. There's indications that it provides clinically significant improvements in symptomatology. What we also find is that the uptake and dropout rates are very similar to what we find in face-to-face treatment. So it seems to be an acceptable mode of delivery for patients. And it's something that's recommended within the NICE and the SIGN guidelines for the treatment of depression. And I guess on the basis of how effective this mode of treatment is, there was a national rollout within Scotland that was completed in 2019, where we've now received over 20,000 referrals on an annual basis. And Chris will maybe talk a bit more in his presentation just about how that's developed quite significantly more recently. In 2019, Tayside was part of a test of change project with 4 other health boards within Scotland, where really what we were looking to do was test whether additional computerised CBT packages could be introduced into our existing service. Really the goal of this was to try and expand the range of clinical conditions that we were able to treat with computerised CBT. And we were initially focusing on 2 packages that were designed for treating anxiety and depression associated with chronic pain and anxiety and depression associated with diabetes. And we were looking to try and establish the demand for the treatment to really see, would this be something that would be a requirement and something that would be used within clinical services. And just as we were about to conclude that test of change project, we were hit by the COVID pandemic. One of the kind of fortunate things, or the good things that kind of came out of this was, I guess, on the basis of the initial findings, that Silver Cloud that we were introducing seemed to be an effective and an acceptable mode of treatment within our departments. That there was a national rollout across the whole of Scotland of an expanded range of Silver Cloud CCBT packages. So those included, in addition to the ones we were already trialling in the test of change that were focused on anxiety and depression associated with diabetes and chronic pain, there was also additional packages that were tailored for anxiety and depression associated with arthritis, with heart disease and with lung conditions, and 2 packages tailored for health anxiety and social anxiety. And within each of these Silver Cloud packages, there's a range of core modules that are each specifically tailored to the associated clinical condition. So, for example, if the patient was referred with social anxiety, the package would contain specific information that was geared towards treating that condition, as opposed to if a patient was referred for health anxiety, the modules that they would complete would be tailored towards that particular condition. In addition to those core modules, there's also additional modules that are available. And that included things like improving well-being during the COVID-19 pandemic. And as with Beating the Blues, the Silver Cloud package again is based on CBT, which is a recommended treatment approach within NICE for those who experience chronic health conditions. And we find that CBT can improve things like treatment adherence, coping skills, quality of life, can reduce mortality rates and healthcare costs. And in terms of the research behind Silver Clouds, there's evidence to show that 75% of patients report significant improvement in their difficulties. Again, it's a package that's very simple and easy to use, where the modules can be completed flexibly at a time that suits. It's recommended that 1 module per week is completed, but the way it's structured means that a patient can dip in and dip out of each of the modules. So they can complete it, for example, if they've got a spare 10 minutes, they can do a bit of work on it, and it'll kind of then link them back to the same part when they next log in again. There's support that's provided through our admin team on a 4-weekly basis, where patients are contacted by email within the package, really with a goal to try and provide encouragement to them to continue completing the modules and to address any technical issues that may arise. So it's not a clinical support that's routinely provided. It's more one that's geared towards encouraging engagement and completion. Again, as with Beating the Blues, the Silver Cloud package is geared primarily for those with mild to moderate difficulties associated with the range of clinical conditions I mentioned earlier. So just in terms of a very brief summary of the packages we have available, we now have Beating the Blues available primarily for depression or mixed depression and anxiety, and then Silver Cloud available for health anxiety, social anxiety, anxiety and depression associated with chronic pain, with diabetes, with lung conditions, arthritis, and coronary heart disease. So in addition to those treatment packages, we also have additional services that we provide within our department, where there's 4 Silver Cloud Wellbeing packages. These are slightly different in that they're not geared towards treating any particular clinical condition. It's more about improving overall well-being. So those packages are available by the patient self-referring to the programme. And those are geared towards managing during COVID, developing strategies for managing stress, improving resilience, and enhancing sleep. We're also just in the process of commencing a test of change that's looking at introducing a Silver Cloud package for generalised anxiety within adolescents, so from the age of 12 to 18. Which will really broaden the age range within which we're able to offer digital interventions. We've also recently introduced IESO, which is slightly different in that it involves providing CBT via the internet, but that takes place in the form of live written messages between a therapist and a patient in the form of an online chat room. So just in terms of a summary of how things have developed over the last 10 years, this is a graph that illustrates the number of referrals that we've had within our department dating back to 2010. So really what this kind of illustrates is that between 2010 and 2016, there was a very modest growth in the number of referrals that we would receive for computerised CBT. So from round about 350 in 2010 to round about 550 in 2016. We then saw a very significant growth in 2017, which was really on the background of the national rollout of computerised CBT and some of the marketing that Chris had been doing at a national level. When I came into post in 2018, part of my role was really to, develop a marketing strategy to enhance, people's knowledge and understanding around computerised CBT. And we saw a kind of a further increase that's really sort of continued since then. It does look as though in 2020 here that it's plateauing off a little bit. But that's really in the context that the referrals are only there counted up to the beginning of November. So I think probably we're on course for getting above the 2,500 mark. So I guess it really illustrates within the last kind of 2 to 3 years just how computerised CBT has really exploded. So in terms of what happens when a patient's referred to our department, we contact the patient by phone within 5 working days, really to give them a bit more information about the programme and to really enhance their engagement, to sort of promote the uptake of it. They're then emailed activation details to set up an account and get started. And then we provide planned support via electronic communication at regular intervals. So our team will be contacting the patient on a regular basis just to check in on how they're doing and to try and promote engagement. There's also administrative support available Monday to Friday, 9 to 5. So if patients are having any kind of technical issues, they can get in touch. And if there's any major clinical issues, I'm on hand to kind of provide some advice. And in terms of engaging with patients, really what we try and do is promote the idea that CBT is about learning skills to help manage issues such as anxiety and low moods. There's a really strong evidence base to show that this approach is highly effective, and that the online format really shows it to be just as effective as face-to-face treatment for certain types of issues, and that the packages that we have available are specifically tailored to relevant clinical conditions. It's quick and free to access and really easy to use, where it gives great flexibility in terms of when and where a patient completes the treatment. So they don't have the requirement to, for example, attend appointments that may interfere with things such as kind of work or family commitments. And that a large number of patients have used this form of treatment and report it to be helpful, and that we'll really provide support with any issues that the patient is experiencing in terms of their engagement with the programme. And I guess one of the things that's really helped with implementing this approach is that we've had a national approach to implementation that Chris will really focus on a bit more in his presentation, where all 14 health boards within Scotland will meet on a regular basis. We have very much a collegiate approach that involves sharing good practice, overcoming any barriers that people are experiencing, and really trying to develop consistent service structures and procedures that we know have good clinical governance behind it, and at the most basic level that we know work. And I guess a big part of that is having oversight from leadership, both in terms of, I suppose, clinical support with the kind of the engagement with potential referrers, but also, I suppose, in terms of how these different treatments are implemented within our service. And that really links into the role that Chris has had and the support that he's provided in doing that. So that's probably quite a natural place to hand over to Chris at this point. And I'll step back for a second. Bear with me a wee second.
Thank you very much, Will. So I'm just going to share my presentation. Give me 2 seconds. I hope you can all see that now. So I'm just going to talk a wee bit about the infrastructure around digital mental health and really its development in the last few years. So firstly is the development of a new role within the Scottish Government, which is my role as a National Advisor for Digital Mental Health. And this role was created in 2020, so I started in post in January. And it's quite an unusual role within Scottish Government because I sit across 2 directorates within the government structure. The first being the Mental Health Directorate and the second being the Digital Health and Care Directorate. And really what this is allowing us to do is to start pulling the 2 worlds together and develop a common approach and a common language, as well as the appropriate infrastructure. And the role really focuses on providing advice and support to ongoing digital work within mental health, as well as providing implementation expertise, both internally and externally. We have started the development of a national programme for digital mental health, and this consists of 5 key areas of focus: 3 service development and 2 infrastructure. So we have digital therapy, online self-management, self-care, and video conferencing or video-enabled therapy, depending on how you want to call it. Underneath that, we have an evaluation and a national approach to evaluation, as well as an innovation workstream. Sitting on top of this is a governance structure which we're in the process of developing now. So we have a digital mental health programme board, which is planning to meet for the first time in January. And this feeds into the two different directorate areas within Scottish Government. So through the Digital Citizen Delivery Board and through the Mental Health Transition and Recovery Programme. So again, this is beginning to pull the two together. Underneath the Digital Mental Health Programme Board, we have an evaluation reference group, as well as short-term expert reference groups, which are really designed to enhance our ability to develop strategy around areas such as young people. The scope of the work is proving to be quite large, I think it's fair to say. So these are the results of a small bit of scoping work that we did in February, just before the COVID pandemic hit. And you can see here there's lots and lots of activity that's currently underway or is planned, covering a range of topics from prevention to prisons, to autism, perinatal, and so on and so forth. But in addition to that, it's very, very important that we're developing the appropriate infrastructure, which will then sit in behind the services and the service development activity. Again, this is also being driven by policy. So we now have digital appearing in a number of our national policies and strategic approaches, obviously including the mental health strategy in 2017, but more recently in the programme for government and the suicide prevention action plan. But I think it's really worth mentioning the context of this policy and what's really driving it. And the primary driver for digital mental health is increasing access to evidence-based therapies. And really this is highlighted by the sheer scale of the undertaking in relation to providing psychological therapy treatment across Scotland. We only have about 1,200 psychological therapy clinicians in Scotland, about 100 whole-time equivalent clinical health psychologists supporting those with long-term conditions, and about 990 clinical staff for our young people services. And really what this is really highlighting is the sheer scale and demand is outweighing really what we can provide in more traditional face-to-face methods. But I think equal to this is also about accessibility of service. And this really just highlights how sometimes our services are just out of reach for a lot of our communities in Scotland. On the left here, we have Lewis and the Western Isles and Barra at the bottom there. It's about 139 miles between these two locations, but it'll take you about 5 hours, 55 minutes to get from Barra to Stornoway for your psychological therapy appointment. Equal to that is the same in places like Shetland, where it would take you about 2 hours, 25 minutes to travel the 60 miles, the length of the Isles. So technology is now an absolute necessity within mental health. And what we have to be mindful of is the range of technologies that are available, such as Internet Cognitive Behavioural Therapy, or CCBT. We have video-enabled therapy. We also have remote monitoring. But there's new technologies emerging all the time. And some of the really exciting ones which are emerging are around artificial intelligence, and particularly for young people. We have gamification technology for things like mindfulness and relaxation. We now have virtual reality being presented as a treatment choice for phobias, for example. But in addition to that, we have things like machine learning, which is really beginning to inform and expand our understanding of clinical practice. So it's very, very important that what we're doing within digital mental health is ensuring that we put the appropriate assessment structures in place. As has been alluded to in the previous presentations, there is a lot of digital apps and digital technologies and products available within mental health, well over 20,000 in the App Store, for example. And really what's important is we're able to identify what's going to be genuinely use, as well as what's going to make a big difference to our mental health landscape. And really what we look at in relation to assessment is three primary areas, which is evidence and safety, need and fit. And this is really about identifying those pieces of technology which we know have strong evidence base and are safe for our patients to use, but also that then fit in to the overall system and have a clearly identified need. In addition to that, we also look at capacity of the services that are going to be implementing them, usability, support, and obviously the technical requirements around the technologies. Everything we do within digital mental health is fully integrated into the existing mental health structures. This diagram effectively illustrates the step care model. At the bottom here, we have mild and prevention, right the way up to the more severe, enduring, and inpatient services. And effectively, what's been shown is that the wider the base, the greater the population. But as you progress up, the greater the need for service. And when we're looking at digital mental health services, we concentrate on the lower half around the delivery of service. So that's digital delivering service, such as computerized CBT. And as you progress up the triangle, you get to the point where you're enhancing existing services through video, for example, the Near Me service. But just a reflection on something that Will touched on, which is really the increase or the rapid expansion of our digital therapy services in Scotland. In 2019, we had a single CCBT treatment for depression and mixed anxiety. And we had about 22,000 referrals in a 12-month period. We had sustained funding for CCBT, and we also had a couple of test of change projects running. Move forward about 9 or 10 months, we now have 8 CCBT treatments for depression, long-term conditions, anxiety. The expectation is referrals will double in the next 24 months. We now have sustained funding in place still for CCBT, but we also now have self-referral options through our Wellbeing psychoeducational programs. In addition to that, we have a national test of change program, as well as identified, and this includes currently 4 projects looking at the introduction of CCBT for young people, for perinatal, for insomnia, and for generalized anxiety disorder, with the insomnia and generalized anxiety disorder being self-referral services. In addition to that, we're rolling out a new service called Internet-enabled CBT, which is CBT being delivered by CBT therapists through written communication, so effectively through web chat. And really just to highlight the impact we're having now in our digital and our CCBT services. So in September 2020, we'd received 26,445 referrals in the previous 12 months. But what we're really seeing is a huge increase across all the services, with October 2020 receiving 3,097 referrals in a single month across Scotland. We've now had around 85,000 referrals since 2015. We monitor the suicidal ideation of 3,600 patients per month. 85% of our referrals come directly from GPs, but we actually receive referrals from about 25 different clinical sources. And the upshot of all this is about 1 in 5 referrals to psychological therapies is now a digital referral. What's very important within this is creating the right environment for change. And when we ever talk about technology, and those that are involved in digital implementation know that there's a huge number of barriers, and the barriers are sometimes invisible barriers to the implementation. And a lot of the things that we have to do in the digital mental health program is really overcome a lot of these invisible barriers. And this includes things like negative perceptions of digital, clinical acceptance, but also things like organizational personalities, where the variation across the 14 different boards in areas such as information governance can be a real barrier to the implementation. And really how we're overcoming this is first of all by developing the right service models, the right implementation approach. And these are really designed to support the rapid implementation of upscale services. But equal to that is about overcoming a lot of the barriers that we're facing as we're implementing. And one of the key aspects of this is the collaborative approach. And again, Will's highlighted the national meeting structure that we have, but we spend a fair amount of our time working with others around the digital mental health agenda. And this includes psychology, workforce planning, as well as commercial partners, social care and primary care. And what the outcome of this collaborative approach is not about development of services, but it's really about developing a shared understanding of need, common goals, and ownership across the work that we do. And a key part of this is really about identifying and defining shared responsibilities. So within digital mental health, we have a clear distinction between the national work that continues, as well as the local development of services. And really what this has enabled us to do is to share the responsibilities. So evaluation expertise and implementation expertise will be hosted nationally and provided to the boards, as well as the continued drive and commitment. And this has really been important, because what it allows us to do is to create the shared learning experience that Will had talked about in his presentation. But what it ultimately means is you really maximise the impact of your partners, the expertise they have and bring, as well as in creating massive efficiencies in the implementation process. And again, another key aspect of the work that we do within digital mental health is really about building trust in the technologies, building trust in the approach, but also then building, equal to this, a trust that the technologies have a role and a function to perform within the mental health areas. And this is really about building common goals, but as well as being transparent about our successes and failures. We have to respond and react to our partners, as well as start the development of clear understanding of what the technologies are designed to do, and really try to address a lot of the misconceptions that may exist out there. And one of the biggest tools we have to do this is the continued development of evidence. And we build evidence all the time, every single day that we're delivering service. And this is really designed to, first of all, support the claims made by the technologies. And this may be technical, user satisfaction, safety, effectiveness, but we also focus on research and the impact that digital therapies are having within the mental health landscape. And finally, one of the biggest areas of work that we do on an ongoing basis is really driving for clinical acceptance. And this is by far, I think, one of the biggest barriers that we face on a daily basis. Within mental health, and particularly within psychology, we're addressing or basically competing against about 100 years of tradition. To overcome this, we have an extensive program of clinical engagement as well as evaluation to develop the appropriate evidence. We work a lot with our senior management groups to develop the support for digital, as well as working individually with individual clinicians around acceptance. And the biggest thing that we can do in relation to achieving this is really driving forward peer engagement, so making it sure that our clinicians are talking to our other clinicians, as well as a strategic marketing approach. Thank you very much.
Chris and Will, thank you both very much. That was a great overview of the progress in Scotland and developments over the last number of years, and particularly focusing on some of that rapid development and acceleration over the past 9 months. Conscious of time, there's been quite a few comments coming through the chat. I guess there's been a focus on, you've talked about it yourselves a bit, digital inclusion, and that's both to do with areas of Scotland, and there was a particular comment or question about rural access, where there are some challenges with 4G and internet connectivity. Therefore, as we roll out these digital therapies, people may not be able to access it due to where they live. But we're also aware of the increasing focus on people who aren't able to access digital, through lack of devices, lack of money to fund data, or lack of skills. And we do have the Connecting Scotland programme underway. Just any brief sort of observations, either of you, on that? And can we do more about connecting in with Connecting Scotland programme to really get a focus on ensuring that people who do need access to these very important mental health services can do so?
Certainly, I suppose the first observation is really about patient choice. So it's making sure we have technologies in place where we are able to overcome some of the geographical barriers. So the use of Near Me, for example, obviously does require a certain level of broadband, but what we've tried to do is really to identify other technologies which then can complement services such as Near Me. So, for example, our internet-enabled CBT service is a text-based service delivered through a browser, and as such requires very, very little broadband connection. And what this is really proving to be is really, really popular in areas such as Western Isles, Orkney and Shetland, where it is difficult to maintain that connection. I think in addition to that, it's also making sure that the digital services that we have are fully integrated into our psychology services and our mental health services. So again, the choice is there So if people aren't able to access our digital therapies, they're not left isolated with no further options to move into. So it's very, very important that as we progress with digital, that we're fully working in partnership with the kind of existing service structures to make sure that digital is one of the choices that people have in accessing service.
Yeah, okay. There's been another couple of themes coming through. One is about, I guess, we've recognised with COVID, while there's always been demand for mental health, increasingly there's a big focus on the impact of COVID on people's mental health. But one group that was referred to was older people who maybe been shielding, isolated, lacking a bit of confidence, risk of falling, where there's some evidence that CBT could provide some support. And I guess the other couple of areas would be people, the long COVID that we're hearing more about, and residents in care homes that again, maybe up until now haven't been supported to access such services. So Will, I don't know if you have any sort of views on that from a clinician's perspective.
Yeah, so in terms of the older people's question, we did a research study probably about 8-9 years ago now. It was part of my kind of doctoral thesis when I was doing my clinical psychology training. That was really geared towards testing whether beating the blues was acceptable and effective for older people. So it was a patient preference trial where we offered this as an additional option to treatment as usual that they were already receiving. And we found about half of the patients that we offered it to would accept it, and that there was both clinical and statistically significant and clinically significant improvements in their difficulties. So it's very much a population that find this approach kind of acceptable and it is effective for them.
So Chris, from a national point of view, in terms of how we support and fund some of these programs and developments and implementation, clearly there's a lot of need out there, and do recognise there needs to be some prioritisation, but there does seem to be additional sort of areas coming through now.
Yeah, absolutely. I think it's particularly through COVID, we've really identified a number of areas. But in addition to that, we've also identified quite a lot of referrer bias, if I was being honest. So there's a wee bit of work to do with our clinicians, particularly our GP populations, where we tend to get a much more bias towards those that are under 30, for example. So we know that CBT works very, very well for over 65. We also know engagement is maintained. But there's quite a lot of work to do just around the changing attitudes of how we get things like CBT recognised as being a valuable tool and a valuable treatment for the older populations. But in addition to that, I think there's quite a number of strands of work that we need to focus on moving forward in relation to key priorities such as younger people as well as older populations.
Yeah, and there's been some sort of supportive comments, obviously, as well about, interested to hear Silver Cloud's test to change, with younger people. I think there was also a question which was relating to the self-referral for wellbeing packages, and there was interest in maybe the community navigator role, but also hearing a bit more. So, Will, I think that was something you mentioned in your presentation.
Yeah, so I think I can only really speak to the way in which we've implemented that in Tayside. I think there's maybe been some slight variation across some of the health boards. Really what we've done is just rolled out the password to get access to it as widely as possible. So things like communicating that out to GP practices, third sector agencies, universities and things like that. So patients can get the information and log on to it. We don't kind of monitor that in any way other than just counting the number of referrals or the number of users that access the programme. I think some other areas, they've gone a slightly different route where they'll ask patients to, in effect, refer themselves into the CCBT department, where they log a bit more, for example, demographic details, and then just give the patients the password to access it themselves from there. So if anyone kind of is in the Dundee or Tayside area and needs more information about that, they can drop me an email and I'd be happy to provide that information.
And just one final point has just gone up there is about the multitude of apps and that aren't necessarily approved or recommended. So I don't know if you have any final comment to say about how that can be supported.
Well, I mean, I think the issue is you're always dealing with external entities who can develop and certainly get approved quite quickly. I think there's a distinction to make around the apps. There's a clinical aspect to this about the evidence base and the safety of use, and there's a technical aspect in relation to does it meet the information governance requirements and the technical requirements. I think places like the App Store and Google Play are good at monitoring the technical requirements and information governance requirements, but not necessarily the clinical requirements. And as we progress, it's going to be quite important that we're beginning to develop fairly robust structures which then allow us to assess the different apps that we are interested in. But a lot of this needs to be driven by the clinical need and the needs of the population. So we need to probably do a piece of work around identifying what is the need and then begin to go to market to identify what's going to be a suitable solution or product.
Okay, I'm conscious of time. We're just gone the sort of 6:45, and I do recognise that people probably have had a long day and need to get some food. But I'm sure we could have gone on for another while. But really good to see some of the comments and interest in this. And again, Chris and Will, thank you very much for giving such a good and insightful presentation and recognising how much work has been done, but also I think, as you can see, a real need still to continue investment and development in this area going forward. So thank you both very much. And thank you all of you who've been listening in and contributing through the chat. So hope you all have a good evening.
That's great. Thank you.
Thank you very much.